Greetings, it's time for another update. A lot's been happening, and I'm terrible at keeping on top of the video updates. So, as usual, this is a long overdue update. I think the last one was probably about a month ago. So, it is coming up to the end of January in 2022, and in July, I had surgery to reconnect my intestines. In fact, actually, I think it was June. And things were fine for a few months while I was recovering from surgery. And then mid-October, I started getting terrible pains, like lower abdominal pains. And that's continued for like months now. About 3 and a bit months. And I went to see the surgeon a couple of times about it, and he gave me some medication to calm down my intestines. He thought maybe my intestines had got irritated from something, or somehow. And the medication seemed to help a bit, but then the problem kind of got worse again. So yesterday I went to see him again, and also I had an endoscopy where my kind of entrance to the intestine was examined with a camera. I had been told by the surgeon that I would have that procedure under sedation, but the person doing the endoscopy said I didn't need sedation. It was quite unpleasant and painful. Last week, I went to have a monthly blood test, and I got the results from the previous blood test, and that was at the cancer clinic, and it was quite concerning because every month I have a blood test, and it's what's called a full count blood test, so it's for white blood cells and inflammation and cholesterol and liver function and that kind of thing. And it also includes 2 tumour markers, which are things you can measure to try and see what's happening with cancer. And I measure 2 tumour markers, CEA and CA19-9. These are used for judging several different cancers. And when I had the blood test last week, I got the result of the previous month's blood test. That was December blood test. And I saw, and my immunotherapist saw, that the CA19-9 is rising. So from I think like October to November it went up 20%, and then November to December went up another 20%. And so September to October 20%, October to November 20%, November to December 60% rise. Now I hadn't noticed it was rising before, so 20% rise because the number's very low, way below the kind of threshold where you'd be concerned. I hadn't really thought anything of it, but it was quite a concern because it indicates that the cancer is there and growing, potentially. But the reason I mention that now is because when I met the surgeon yesterday, this is a surgeon who did my reconnection of my intestines last year, about 6 months ago, when he did the surgery. When I met him yesterday, he wasn't particularly concerned about the rising level of CA19-9. He said it could be caused by a lot of things, and also it tends to fluctuate quite a lot anyway. And so anyway, I had this very unpleasant endoscopy, and then I went to meet with a surgeon and discuss what the endoscopy found. And what the doctor found who did the endoscopy was that the entrance to my intestine, or rather the end of my intestines, so where it was reconnected, has become incredibly narrow. So just after surgery, so if you can imagine, like, your intestines get reconnected and the surgeon staples it together. In some cases, they may do like hand stitching, but my surgeon used staples because you can reconnect the intestines with kind of less less overlap of the intestines, I guess. So in my case, it's really important because the reconnection point was really low. So if he had, if the surgeon had like hand stitched it, I'd have had an even shorter bit of a lower intestine. So what he's found, yeah, on the imaging, or the, I guess the photos really, stills from the camera, is that the joining point, so it's called anastomosis, so where the intestine has been reconnected, it's become incredibly narrow. It was like 25 millimeters wide, just yeah, at the time of surgery, and it's now gone down to like 5 millimeters. So that's, or 3 to 5 millimeters. So that's what's causing the incredible pains, these like waves of pain, lower abdominal pains, and it's serious and dangerous and needs to be corrected. Which means I'm going to hospital on Saturday, and for various reasons, which I'll explain, I'm going to be there for like 12 days or more, to have this surgical procedure, so under general anaesthetic. And so the procedure is going to be to like widen this place where it's kind of the scar tissue has kind of developed and narrowed my end of my intestine, and yeah, so this sometimes happens like a few months after this surgery that I've had. What is strange and puzzled the surgeon a lot, and is potentially quite concerning, is that the surgeon could not see why it had happened, what the cause was or is. So he was looking at the pictures and sort of saying, the connection looks really good. The blood supply seems to be good. There's almost no kind of inflammation or irritation or anything around there. He showed me some pictures from some other random patient, where you could see like so he showed me examples of like narrowed intestine, or narrowed anastomosis, and it looked so different to mine because it was all kind of inflamed and looked horrific, and mine looks kind of kid-a, as the surgeon put it, which is like, means kind of clean and beautiful. So it kind of is a bit concerning. And this procedure, which I had read about because I had thought kind of this may be one of the possibilities. It's an endoscopic procedure, so they don't need to cut you open or anything. But yeah, this will be under general anaesthetic, and they put some kind of balloon-like device in and kind of stretch the anastomosis, and presumably the tissue is like destroyed or whatever. I did kind of try and press the surgeon on like what exactly happens inside, but he evaded the question. And he said I might need it, or I'll certainly need it done a couple of times, possibly 3 or 4 times, with like 6 months between each time. So the plan is to go and have this procedure and then wait a month and then do another kind of endoscopy check, and then do the procedure again like 6 months later, and another month wait, and then endoscopy. Hopefully I'll get away with just doing it twice. So I've actually heard of this procedure being done with like just local with kind of anesthetic, like a local anesthetic, presumably something quite major, and sedation. But in my case, it's like general anesthetic. And the reason like I'm staying so long in hospital is that the surgeon says that like usually you'd have kind of drink a load of stuff to clear out your intestines, just like when you have a normal colonoscopy or whatever. They give you like 2 liters of this disgusting syrupy stuff that you drink over a period of hours. He said it's kind of dangerous in my case because the anastomosis is so narrow. So instead, he says, why don't I starve myself? And yeah, then do the procedure. So he wants me to go into hospital on Saturday morning and spend 5 days just chilling at the hospital, not eating anything, just drinking a lot of water, and presumably I'll have like a nutritional drip as well, like a kind of a zero residue or very low residue nutritional drip. So I'm going to have like these 5 days of complete fasting, and then do the procedure next week on Thursday, and then Friday will be just drinking water and the drip, and then a few days of observation in hospital, eating kind of watery food. So in Japan, when you're in hospital, you and you've had like digestive surgery, so kind of surgery on your intestines, your stomach or whatever, you have this stuff called okayu. In Chinese, or like in Cantonese, it's a congee. So it's like rice porridge, and you're given it like with varying percentages of rice and water, starting off where it's like almost all water with a tiny bit of rice in, and after some days you kind of eventually progress to like just a watery porridgey rice stuff. It's pretty nasty. So that's what's going to happen. The one very positive, or potentially very positive thing, as I said, is that the surgeon is not concerned about the rising tumour markers, and he said that it could even be caused by the intestine problem, by like the scarring and stuff. So that's the update really. So I have to plan my hospital stay. It is Wednesday now, so Thursday and Friday. So next couple of days I'll be preparing and packing. And I always kind of wonder like how to spend the time most optimally in hospital. And when I have surgery, I always find I'm far busier than I expect, even though I've had it several times now, these big operations. However, in this case, at least for the first 5 days, I'm going to be just have nothing to do other than blood tests and blood tests really, and other kind of vital sign checks and stuff throughout the day. So I should have quite a bit of time on my hands. Because of coronavirus, there's no visitors or anything. So what I thought is that I'm going to read a couple of books. When I say read, I'm going to make a big effort to not just read them, but actually study them properly. So I'm just looking at my monitor. So this is High Growth Handbook by Elad Gill, and it's basically interviews with startup people about, well, the subtitle of the book is Scaling Startups from 10 to 10,000. This is published by Stripe Press. So Stripe is like a payment processor, a bit like Square, although has Square been renamed recently? I forget. Stripe is a really good online payment processor that I use, in fact. And bizarrely, they have a publisher as well, and have published these really like impressive set of books. So High Growth Handbook, I will be studying that because I'm in the process of getting a non-profit off the ground to cure cancer. And the other book I'm going to read and study is The Dream Machine. So not to be confused with Dream Machines by Ted Nelson. This is The Dream Machine. It's hard to kind of look out the corner of my eye at the monitor. So The Dream Machine, this is JCR Licklider. So it's a biography of Licklider by M. Mitchell Waldrop. And Licklider is, or was, I guess you could call him a computer scientist. He was actually a psychologist, and he was one of the real driving forces behind ARPANET, which later kind of evolved into the internet, and which the web is built on top of. Licklider is kind of an incredible person. I've studied about him a bit, and I've read a couple of his papers. And he was at ARPA, the Advanced Research Project Agency in the US, which renamed itself DARPA later on, the Defense Advanced Research Project Agency. I think Licklider also may have spent some time later at Xerox PARC, I'm not sure, with Bob Taylor. So Bob Taylor is like the person who gave us modern computing. Licklider and Bob Taylor are two of the people most responsible for what's called the computer revolution. And I think, it's kind of fair to say they're responsible for some of the good aspects. And interestingly, both of them psychologists, and one of the core similarities between them is that they both realized that you should focus on people, not projects. So instead of like looking for interesting projects to fund, Licklider at ARPA, he had a budget and could give money to researchers to research techie stuff. And Bob Taylor was running Xerox PARC later on, and when people like Adele Goldberg and Alan Kay were there, and I guess Larry Tesler, and all those kind of people. And Bob Taylor was kind of managing it and deciding what would get funded and researched and stuff. They both kind of worked out that if you get the right people and create a good environment for them and give them funding, the projects they're working on, like the specific projects, are not so important. Like you'll generally get amazing stuff happening. Alan Kay has called this reverse graffiti. Just put smart people in a good environment and they will create cool stuff. So yeah, very much looking forward to studying these 2 books. And hopefully I'll get through them. It's hard to judge how long they're actually. They're both like have really small print and they're like 400 or 500 pages each. Licklider one's about 500 pages and High Growth Handbook is like 400 pages. So that's what I shall be mainly spending my time in hospital doing. So this procedure, although it's like under general anaesthetic, it shouldn't hopefully involve like being cut up and stuff, although it might go wrong and there could be complications. And I guess if the surgeon can't like get this balloon procedure to work, then he's just going to start hacking away at me from the inside, which may result in more scarring in the future. We shall see. So yeah, I mean, as usual, when I go into hospital, like I try and go in with the intent. Yeah, I go in with the intention to use the time very well and to try and just like make the lives of the staff as pleasant as possible, because it's it's an incredibly tough job working in a Japanese hospital. I mean, working in any hospital, but the Japanese healthcare system is it's fantastic, but it is extremely lean. Staff work crazy hours as they do around the world, but I can't ever complain about being in hospital when I'm being treated by a nurse who's on a 14-hour shift, and it's nothing that I've been through in hospital compares to what the staff go through every day. So I make a big effort to kind of be a good patient, and this time will be no exception. I'll try to do some exercise in the hospital as well. I didn't ask the surgeon if I'll be on a drip, but in Japan at the hospitals they're obsessed by drips, and presumably I'll be on like 24-hour nutritional drip, which is really annoying because of course you wake up many times in the night to go to the toilet and stuff, because you continuously have stuff being dripped into you. So and also that limits what I can do in terms of exercise and stuff while I'm there. As I mentioned before, we have some coronavirus in Japan. Numbers are getting kind of high here, so no visitors for the hospital. When I enter hospital on Saturday, I've got to go through like the normal PCR test and stuff, and with the painful nasal swab, although I'm going to try and get out of that actually. And the kind of situation in Japan is it's not like bad in any way compared to other countries, because this is Japan. It's concerning. How can I explain? It's concerning that there's just so many people having coronavirus finally in Japan, which means some of those people are going to be severe cases, just because the number's so large. There are effective antiviral drugs available now in Japan for coronavirus, so they can treat even severe cases very well, but it still is of concern, and of course it means people are having to cancel events, and yeah, it's just a lot of hassle. Still, overall, yeah, Japan has done incredibly well, whether that's by design and competency or by luck or whatever is another matter. For me and my family, coronavirus has had no impact whatsoever, other than not being able to travel out of Japan, stuff like that. So yeah, for me it's just a hassle of not being able to have visitors in the hospital. Yeah, other than that, I'm making bits of progress with the non-profit. So getting this non-profit set up called Make Cancer History. So what I'm working on at the moment is putting together an advisory board. So these will be like a group of unpaid advisors, probably 6 people, I think. 3 will be medical people, 3 will be from the tech world. And yeah, they will kind of give me and the volunteers and stuff advice about various aspects of outreach and running research programs and getting the pertinent information to the doctors, researchers, and patients, which is initially what the NPO, the non-profit organisation, is focused on. Is really connecting cancer patients and cancer doctors and cancer researchers together to actually make some progress on cancer, because there's just a whole bunch of issues in the way that cancer is researched and the way that the treatments are developed and used. These issues are not necessarily related to money, more of like getting the money to the right places, and also the kind of the culture. It's a very inward-looking culture, like all the medical world is, and in fact, like the science world is actually. And yet, all the breakthroughs are going to come from outside the medical world. So, particularly with cancer, some of the key things will be engineering breakthroughs, and in many cases, it's like the breakthroughs have already happened in the engineering world or the tech world or the startup world, and this hasn't kind of trickled into the world of medicine because of just how the things are structured. It's like that quote, possibly wrongly attributed to the author William Gibson, that the future is already here, it's just not evenly distributed yet. So what we need to do is get some of the future and put it into the medical world, and become far more outcomes focused, and work a lot more on the process of research and the dissemination and like of the research, and when we have better treatments available, which we have in some place in the world, getting those to scale so that they can be done cheaply, safely, efficiently, everywhere, quickly. And these are all things that the tech world is pretty good at. Maybe some of us would argue that the tech world is very focused on things that aren't so important, but we can't deny that some of that stuff gets done really, really well. Xerox PARC being a case in point. The progress made at Xerox PARC in really quite a small space of time, and with not many people, and in fact without a massive budget in total. So the budget at Xerox PARC was very high, per researcher, but it was actually a small number of people who essentially made practical modern computing, modern programming, networking, and the graphical user interface. Now, some of that, of course, was developed at Stanford Research Institute, and some of the people from SRI went on to Xerox PARC, so they had a head start, but still, they achieved an incredible amount in a very small space of time. And when I think Alan Kay was talking to Bob Taylor about how much it would all cost, and Alan Kay was saying about needing the best people in the world, and he said to Bob Taylor, it's not actually going to cost a great deal because there aren't many people good enough. So even though like the funding per research was very high, the total for running Xerox PARC was not an insane amount of money, and nothing like the money in big tech at the moment. So using those kind of the methodologies that places like Xerox PARC and of course Bell Labs and Menlo Park and Stanford Research Institute and ARPA, using the kind of ideas and methods that they have, that they used, we can really make a big difference in the medical world. So that is my focus at the moment. Thanks a lot for listening, and there'll be an update when I get out of hospital in a few weeks' time. Until then, take care of yourself, and thank you so much for your support. And if you want to help out with the NPO, get in touch. And if you want to help out financially, then if you just donate to my GoFundMe. And at the moment, I don't need any cancer treatment, so that's all going to getting the NPO up and running. Okay, thanks a lot, and talk to you soon.